Echo intensity, it's really challenging to say it's this or it's that. I tend to say it's a rough measure of the non-contractile tissues.
Is it fibrosis mostly? Is it fat infiltration? And what is going on with the muscle?
If you have huge muscle, the sound will be attenuated, and then the results in terms of echo intensity will not reflect the reality.
But it was very interesting when we did just the basic fat adipose tissue calculation.
Welcome to the next episode of Science in the Break. And in this episode, we are very excited to chat with experts about ultrasound, and in particular, measuring muscle composition with echo intensity. And then I don't know what you want to say with that.
So in this first video, Thea, we will discuss about four main topics. The first one is which is the effect of the ultrasound acquisition parameter. Then we will discuss about the probe positioning, because if you tilt the probe, you can have different results, and also where do you place the probe with respect to the muscles. Thickness, because the larger is the muscle, then the more is the beam attenuation. And the last point, the real meaning of echo intensity. What does it really represent? Echo intensity for the tissue is fat infiltration, just not contractile tissue, fibrotic tissue, who knows? I don't know.
So I'm so excited to have you here today to talk about ultrasound, and in particular, our focus today will be on using ultrasound to quantify muscle composition. We'll start with the first question, just to get the audience kind of informed about your background with ultrasound.
So my background with the research is mostly to do with strength and conditioning and exercise selection, contraction types for athletic populations. So most of the echo intensity research that I've done was in healthy resistance trained populations. And part of it was looking at reliability at different portions of the quadriceps muscle. And then in a later study, the short-term effects, what happened immediately after exercise and then over the course of a week when they were recovering.
With respect to Dustin, I was a bit more lower. I was analyzing mostly the medial gastrocnemius in children with cerebral palsy. And the idea was mostly to analyze the muscle morphology, but as a secondary parameter, we started to use echo intensity to infer about the muscle composition.
So my experience with ultrasound and echo intensity is pretty wide ranging. I've focused a lot on university and community dwelling older adults. My real interests are in aging and how the muscle composition changes with aging. And I've really applied ultrasound across most or many muscle groups across the body.
So we have a very broad speakers today. This is great. I guess one way to measure muscle composition has, in the most popular way in the literature, has been echo intensity. So what is your experience with this measure? What do you think are some limitations or advantages of this? This is just open discussion on echo intensity in particular. And when you were recording echo intensity, did you notice anything in particular that maybe hasn't been mentioned in any of the manuscripts or publications in terms of like not working?
I think it would be very interesting if going forward there was some way to post hoc change the brightness and the settings and things like that. I think that would be pretty awesome, actually.
It depends on the ultrasound unit. Some of the newer ones where they can store the raw radio frequency data, you can actually go back and change things like the gain of the system, so the brightness of the image, and like the time gain compensation, because these are all post-processing images. So as long as the ultrasound use can store it, which not, it's a nice feature to go back and actually adjust some of these things. Not everything, like the probe frequency, for example, has to be preset.
I had some experience in changing the parameter afterwards. You need to keep your settings the same if you want to be consistent in your analysis. But let's say it wasn't the goal, but for some reason, at a certain point in a study that I was related with the parameter change, the settings change. So basically we had two different settings for the same study. So what we have done actually was to find a relation between the two settings with a conversion equation, which is not the best scenario, but it can work. So basically the idea is to have or a phantom object, or if you can do with the same person at the same day, you can acquire the same feature with different setting and then relate them. So then you can go to setting 1, to setting 2, or the other way around.
Yeah, because I remember when I was piloting for Echointensity, there was also, you know, the tilt of the probe, right, would influence the measurement. So, I mean, how do you, for example, guarantee that between sessions, let's say you're doing a longitudinal studies, that your probe is oriented always the same way, and, you know, consistently across or within that person? Is there some hack to do this?
I personally use like probe holder, fixated the probe holder to the leg, and then with like rule of thumb to have the aponeurosis as bright as possible, so to be perpendicular. But that one is definitely limitation, and that's why I'm more in favor of 3D analysis. So basically with the tool that I developed, I could have a 3D view of the muscle. So I had actually the freedom to choose afterward cross-sectional area, and that can help in the reliability of the analysis.
What I've seen, I mean, what I personally do in terms of probe placements is a challenge in terms of like the landmarking of, if you're not doing the 3D analyses and you're picking a single landmark. I personally think that's probably one of the more variable aspects of any protocol, is actually deciding where to take the image. Finding bony landmarks is always challenging, especially when you're talking about diverse populations who may have more or less subcutaneous adipose tissue. But if, let's say we had a consistent placement of the probe, orientation of the probe is also challenging. I tend to just do like some tilt methods until I get bright fascia or a bright bone background, because as you tilt the probe, you'll see the fascia or the bone increase or decrease in brightness. That's the one method I've personally been doing, but I've also seen other people where they will attach some sort of inclinometer to the probe, in which you can actually measure the angle of the probe, and you can sort of standardize it in that approach as well, but requires some more custom approaches. We
could even discuss about the thickness. If you have huge muscle, the sound will be attenuated, and then the results in terms of intensity will not reflect the reality for the muscle. Yeah, tissue depth is, as you mentioned, with the beam attenuation, is a huge factor with ultrasound and echo intensity specifically. Like there's the muscle thickness, and that the superficial part will have a higher echo intensity than the deeper part, just because it's higher up, and so the beam attenuation at that point is a little less. But then we also have to consider the effects of the subcutaneous adipose tissue over the muscle, and how the beam is attenuated traveling through the fat of the overlying the muscle. And so those deeper muscles, or people who may be who have more subcutaneous adipose tissue, it's very challenging to compare echo intensity across those individuals. When I was taking the measurements on resistance trained men, there was actually a pretty large discrepancy in the amount of fat mass. There was a couple of outliers that had a fair amount of subcutaneous fat, mostly on the proximal portion of the thigh. And but it was very interesting when we did just the basic fat adipose tissue calculations, or accounting for that. It was very cool to see like the single data points all kind of like converge a lot more closely together. So that was just the calculation from Young and whoever he wrote that paper with. So the subcutaneous fat correction, at least in my experience, seemed to kind of mitigate almost all of that.
My question, coming from the clinical background, is with the echo intensity, really the only thing that you can tell from this measure is basically fat infiltration, right? From my understanding, you can't really tell fibrotic tissue. You can't really tell, or you can't really separate the difference between like fat, fibrotic tissue, etc., right?
Yeah, so I think it's basically the dark part is like water and things that are not going to be reflecting the waves. And then the white sort of tissue is literally everything else. So, I mean, because if you take the measure at a distal or proximal portion of a muscle where, you know, it's starting to come into the tendon, then it's going to be much brighter, even in very young and lean individuals. So that sort of leads into another question that I have, that I think somebody needs to do eventually, is look at the acute differences in echo intensity, so pre and post exercise. So what is changing in the muscle that is causing more refraction? Is it actual damage to the fibers? So the fibers are you know, bouncing back the waves a lot more? Is an increase in a specific type of metabolite? And if so, what is it?
In terms of validity, I remember a study probably 10 years ago, quite famous, from Pillen or Pitcher, I don't remember, but it was on dogs. So they made like a biopsy and they correlated the echo intensity with the muscle composition.
Echo intensity, it's really challenging to say it's this or it's that. And so I tend to, whenever I discuss echo intensity, I tend to say it's a rough measure of the non-contractile tissues, because it is influenced by many factors like the hydration status, if there's any swelling, and this, one of the things Dustin brought up is exercise. Like acute eccentric exercise where you induce a lot of muscle damage can acutely influence echo intensity, but it's actually about 2 or 3 days later that you actually see the largest changes in echo intensity, using like eccentric models of muscle damage. And that might be due to infiltration of like immune cells into the muscle that's breaking down a lot of those tissues. And there's been some work in critically ill patients where they actually obtained biopsies and they saw the echo intensity was actually associated with myonecrosis of the muscle. And so there's many factors that can influence echo intensity. So it's really challenging to say it's one or the other, in my opinion.
I can add a bit more about quantifying fatty infiltration in muscles. I know the attenuation of the mass of the contractile and the fatty is really different, and then they can do like signal processing analysis and see like the harmonics of the different wave and try to infer about the different components. I have the feeling that maybe in a few years there will be ultrasound machine with this kind of package inside, and it will be great to try for sure.
Yeah, I mean, in terms of like, you know, clinical populations and cancer in particular, because we have radiation, right, that kind of some cases blast through the muscle, right? And there's this really big interest in like, is it fibrosis mostly? Is it fat infiltration? And, you know, what is going on with the muscle, I guess, during and after radiation? And how can we combat these kind of effects of radiation on the muscle in cancer patients? So, you know, being able to tell, I guess, what is atrophy of the muscle, you know, because of fat infiltration versus what's fibrosis and atrophy because of fibrosis, I think it would be highly valuable in a clinical setting, and also I think for anyone in cancer research in particular.
It was great to have Mike, Dustin, and we had a great discussion. At least for me, this kind of discussion was really important for understanding how to manage echo intensity, because all these shades of gray can be really dangerous, I think, if you don't really know the meaning. So I hope this one can lead to a further discussion, because obviously we covered just a limit part of this complicated topic. So we are open to suggestion and maybe make a new video.
Welcome to the, yeah, I can say it, right? So wait. Okay, so.
Nobody knows, basically.
Nobody knows.